Hi, New Beauty followers. Welcome back to another New Beauty Talks. I'm features editor Tatiana Bido, and today we're talking about breast surgery 101. And joining us is Houston, Texas plastic surgeon, Dr. Olga Bachilo from Glamour Plastic Surgery. And she's going to just give us the 101 breakdown on breast augmentations, breast lifts, breast reduction treatments. Let me add her. And I hope you're having a wonderful day today. And we are going to answer all of your breast questions. Hi, Dr. Bachilo. How are you today?
Hi, Tatiana. I'm doing great.
So you are well known for your breast and body work. So you're the perfect person to talk to about this today. And I know our readers have so many questions. They're never ending. And this is one of our number one topics. So my first question is, what are the most common breast surgeries that people come to your practice wanting to know more about?
So by far, the number one procedure most people are interested in is the breast augmentation. And I mean breast augmentation with an implant.
Right.
Other options, of course, include augmentation with more natural things like fat, which is number two. Breast lift and breast reduction, I would say, would be the second most common procedure that I see. And then finally, augmentation with lift, so combining the procedures to achieve the best results.
Do you have a specific age range that's coming in for certain procedures? Like in your 20s, are you looking for an implant? When are people looking for a lift or a revision?
So the range of my patients is actually very broad. It can be as early as 20s all the way to, mid 60s. My younger patients generally are looking for an augmentation or breast reduction. Actually, it's a very common procedure in the younger group. My mid 30s to mid 40s usually are looking more for a lift, maybe with an implant. And at that age group, I see more of revision surgery as well. Because they may have had an augmentation in their 20s and now they've had a couple of kids and it's time to kind of revise things, maybe lift that breast up again, exchange the implants. Maybe they decided they want a larger size at this point, or maybe they actually want to downsize their implant at that point.
So can you walk us through what's on the breast surgery menu, from breast augmentation to a breast lift to a breast reduction? And then I know there's one in there like breast lift with an implant. So what is the difference between all of those?
So with the breast augmentation, we do have a couple of options. There is an augmentation with a saline implant versus augmentation with a silicone implant. I have an implant right here in front of me.
Nice.
This is one of the silicone implants. It's always going to be more natural feel. It's going to get a more natural appearance. So this is by far the number one choice for most patients.
And that's a silicone implant.
This is a silicone implant.
And then what's the difference between a silicone and a saline?
So with the saline implant and the silicone implant, the outer shell, so the casing is always going to be silicone. What's different is the filling inside the implant. With the saline implant, it's filled with water, saline water, just like IV fluid. And the silicone implant is filled with a cohesive gel. So what people refer to as the gummy bear gel.
Right.
The difference with that gel versus the gel we had 20, 30 years ago is it's more cohesive, gummy bear. It doesn't leak. So it's not like liquid. If you cut an implant, the gel can protrude out, but it doesn't spread and leak out all over the place.
Nice.
So the main kind of difference happens is when the implant ruptures. The saline water will get immediately absorbed by your body, so it's almost like getting an IV fluid. So within a day or two, patients will see that suddenly their breast is pretty flat. With the silicone implant, you may not see a rupture at all. So the gold standard to determine if there is a rupture is an MRI. However, the gel doesn't go anywhere, so it just sits there until we're able to diagnose a rupture. And if we know that it's ruptured, I definitely recommend a replacement, but it's by no far as an emergency where you have to rush in and get the implant replaced immediately.
So what is the benefit of the gel implant? Is it feel? Is it shape?
It's a little bit of multiple things. So number one is
Yeah.
the feel. It's going to mimic the natural breast feel better than the saline implant. You also have a lot less risk of seeing rippling, so the little lines and kind of folds in the breast with the silicone implant. For the same size implants, silicone is actually going to be lighter, so it's going to be less of a tissue stretch. And rupture rates are slightly less with the silicone implant, so you can, potentially keep the implant longer. And the shape, they're all going to produce very pretty shape. Most of the time, we put the implant under the muscle, so patients will still have the nice teardrop natural shape.
I was going to ask, so it's under the muscle, and then how do you place it in? Is it under the armpit, underneath, the breast fold?
So there's multiple options for that. My most preferred method is under the fold. Under the fold incision is about 1.5 inches long, so it's a small incision, very, very well tolerated. It's the best access as far as safety goes. Make sure that the implant is well positioned. For younger patients, if they're gonna need revision surgery, that will be the preferred incision for any revision surgery. So I say, you're gonna have then one scar, which
Right.
as a surgeons can use, I can use again in the future. My second preferred method is through the armpit. And through the armpit, there's a limit on how big of an implant we can place through that type of incision. There's also a little bit of patient candidates, so not everybody's going to be a candidate for that type of procedure.
Right.
There's a little bit more risk for implant malposition. A little longer procedure, a little bit more discomfort because we stretch the muscle more, but generally a very good option for smaller patients with darker skin who may be worried about their incision on the breast being more visible. So that is my second choice.
And for a breast lift, what does that entail? And then that one has an option of with or without an implant.
Yes. So for the breast lift, there is a couple of actually different procedures that can be done depending on how much we need to lift those nipples up. We may need to do just as simple as periareolar lift, meaning just cutting around the areola. So that means there's a circular scar around the areola that gives us an opportunity to make the areola smaller and lift them up. The second option is going to be a vertical lift. So that means a lollipop. So that includes incision around the areola and then up and down. That's going to be a great option for patients that have a little bit more of skin hanging, kind of touching their chest. So we can make the breast a little tighter, lift that nipple a little bit more as well. And then finally, there's the full anchor type scar incision. So that will include the incision all the way around the areola, up and down, and then all the way across the fold. And that type of lift is reserved for patients who have quite a bit more extra skin and need a little bit more skin removal on their breast. With either one of those lift procedures, we can incorporate the implant at the same time to give them a little bit more of the upper breast fullness. Very often patients who do need a breast lift, they've lost a lot of their natural breast volume, maybe because of aging or breastfeeding, and so they literally have kind of a scooped appearance of their top breast. So combining the procedures where we put the implant to restore some of that volume, plus repositioning the nipple and the breast tissue would be the best option to do for those patients.
And then do you get a lesser scar if you do a breast lift with an implant? Because I know with a traditional breast lift, the scar is kind of non-negotiable. I know they fade over time, but you will have, a noticeable scar for a little while.
So with any breast lift, there's going to be more scars than just doing the augmentation. With augmentation, it's 1.5 inch scar under the fold or maybe in the armpit. With the lift, there's going to be always a little bit more scar. Patients are always afraid of the scar, but it's a trade-off. It's a trade-off for a beautiful shape. So I always, if I see a patient that is a candidate for the lift, but they're hesitant about the scar, they can't get the type of shape they need just by putting an implant. I do unfortunately see a lot of patients that choose to go somewhere where they get talked into putting a very large implant.
Right.
Because, putting a large implant, we can stretch that skin a lot. But when we stretch the skin, the gravity still takes effect. So just by putting an implant and stretching the skin, we're not really lifting the breast. The breast actually gets heavier, and so it can actually migrate lower in the chest. Every time I see that happen, patients are very unhappy. They end up coming back and doing some kind of surgery a year out because they realize, first of all, they didn't want that big implant. Second
Right.
of all, they did not get the lift that they're looking for. So if they're a true candidate for a lift, they absolutely have to, sacrifice and, go with the full scar.
Embrace the scar
Embrace the scar.
that will eventually fade, right?
Yes,
Hopefully,
and
yes.
I've done breast surgery for a while now, and I don't have any patients that have regretted going with the lift, even
Right.
if the scarring required some additional attention. There's a lot of things we can do to help scars fade, and so I always, discourage patients from not doing what they need to have done just because they're afraid of scars.
Right. And then is there ever a case where you're not a good candidate? Like, can you have breasts that are maybe too dense and an implant cannot go in there? Or, is there ever a time when it's just the lift or reduction is all you can kind of work with?
So, when I see patients that may have a lot of their own breast tissue and they have a nice shape, maybe they're double D and even bigger themselves, but they still want more of their breast at the top.
Yeah.
Sometimes we almost do more of an exchange type of situation where we do a small reduction and we put a small implant, and that's to reposition the location of that breast. The implant will always stay higher. So
Yeah.
to give them that volume at the top, we put a small implant. But as a trade-off, we remove some of their breast tissue that's hanging low so that they end up with about the same volume, but now their breast is remolded and is perkier at the top.
Yeah. I know a lot of friends and women in my age group who are happy with their breast size. It's just the gravity has, in your 40s has taken over. So there's a lot of questions about breast lifts and reductions and things like that. So it's good to know all of the different options that are out there. What about a breast reduction? What does that entail?
So I think of breast reduction as kind of being on the same spectrum as the breast lift. Okay, so it's technically the same procedure. We perform it. Technique is very similar, and at some point in that spectrum, depending on how much tissue we remove, it becomes a breast reduction as opposed to just the lift. Every breast reduction has lift built in it. Especially when we deal with insurances, insurance companies have a cutoff. They say anything above this volume, or it can be patient specific. We call it medically necessary lift. If you don't meet those numbers, you're a lift.
Yeah.
For the breast reduction. But scars are very similar. Generally, with the breast reduction, we have a little bit more extensive scarring, so it's usually at least around the areola up and down, sometimes across the fold as well, because we need to be able to remove some of that excess skin as well as breast.
And that alleviates a lot of back pain too.
Yes.
It's not just cosmetic.
Exactly. So breast reduction, I would say, patients, it's the most satisfying procedure for me personally and for my patients. They're extremely happy because not do they get perkier breasts, they're able to wear better clothes, but they get the relief of their back pain, and they just feel better. They can perform more physical activity as a result. So it's definitely a very, very high satisfaction procedure.
Yeah, it's life-changing. Okay, so let's talk about implants and how you choose them with your patients. Is there a certain way you should be looking at implants and what's proportionate for you? And what are you looking at? Size, shape? What are the criteria?
So first discussion I have with the patient is silicone versus saline. And I give them information about both, and I let the patient decide what is going to be the best option for them. For patients who are really looking for that peace of mind, they want to know that when their implant ruptures, saline may be an option. But if they're going for a larger implant, I may try to convince them to go more with silicone, just because it's going to give them a better feel. And if their breast tissue is very thin, I don't want them to see that rippling from the saline implant. when deciding on the size, most patients have some photos with them, and I encourage them to bring pictures of what they like, because bra cups are very arbitrary. What one person thinks is a C cup is not the other person's C cup. Even if you go to different stores, C cups will vary very different from store to store. I say, Victoria's Secret, as long as you have breasts, you're at least a D cup. Because they put enough padding into their bras to make everybody at least a D cup. So I'd like to see what their ideal size is. Second aspect is measuring patients' chests. So we want to make sure that the implant we choose fits within their tissues. If somebody's very petite, they're very narrow, they don't have a lot of tissue stretch, and they come in and they say they want a 700cc implant, it's probably not going to happen.
No.
There's no physical ability for us to do that, at least in the first stage. So we want to make sure that implant width-wise fits on their chest, and then we can play with the projection. So when it comes for the final volume of the implant, they come in certain diameter and they come in different projections, and the projection is going to kind of decide more of that cup fill. Another thing that we do in the office, we have them put on a bra and try some implants in the bra, because that gives them kind of a feel of what it will look. They can look in the mirror, they can take some pictures to see how they feel about those implants, and they can show it to their friends or to their family members if nobody came with them to their appointments. In the bra, the implants will always look larger, so I tell them, if you like the size in the bra, we want to go a little bit fuller in the tissue, because they're going to lose about 15 to 20% of that projection. So if a patient like the 300cc implant in the bra, then we may go with like a 360 in surgery.
So when you're trying on the different implants and the different sizes and the projection, how do you, if your own breasts are underneath, how can you tell what's a good fit? Is it just like a visual?
It's a visual and feel as well. So we have them wear a very tight bra, so that those implants we put in there can get a little bit compressed. Of course, it's going to vary depending on how they put the implant in the bra, so we kind of guide them on that. We always have them put on a t-shirt on top so they can see more of a silhouette of their body.
And do people typically think they want a bigger size until they put it on? What is the misconception on choosing?
Very often, I see two groups of people who know what size they want, and we usually kind of come up with a very similar size because they've already seen pictures. They are very good about looking at before and afters and looking at specific body types, and so they come in and they say, I think I want a 400, and as we try implants, we usually narrow down to about 400. And then I have patients that really look more for guidance and recommendation, so I guide them in that aspect. When we're actually in surgery, I don't guarantee a specific size, because cup size can vary from bra to bra. It's more of a look and feel. I always have several sizes available with me to surgery, so that when we're in surgery, I put in a sizer. I sit the patient up, we take a look at their breast. I have their wish pictures with me at that point as well, to see how closely we're able to match those images.
So you're doing it during surgery. You can match it right up and see if it's
that final size, but usually it's pretty close range of the implant. So I may have like a 400, 450, 500, and then we narrow it the final size in surgery.
And then I'm always just curious, when I speak to my doctors, you're in Houston, Texas, is the aesthetic a certain look, or is it really patient specific?
It's very patient specific. There's also a little bit different demographics for each doctor. So most of my patients are women my age, a little older, younger. They're more looking for natural results. They still may want a nice full breast, but they're not looking to have the implants that are way
Right.
out there and, so everybody can tell. Most of the time they say, I want it to be not as noticeable when I'm fully dressed, if I'm at work, but I want to be able
Right.
to dress them up for holidays and vacations. So this is kind of my demographic, um, more
A natural.
field.
Yeah. A lifted natural look.
Yes.
Yeah.
And every doctor will kind of have their own demographics, what they're better known for, and the type of patients that they will attract as a result.
Okay. What about nipple repositioning? Is that always part of every breast surgery?
So it's part of the breast reduction and breast lift. The reason we're lifting, technically, we're lifting the nipples. We're also repositioning some of the breast. So that's part of those. With the augmentation, the nipples relatively stay in about the same place. There's a little bit of rotation that happens, but we don't physically change the location of the nipples.
And then if you do reposition the nipple, does the patient lose nipple sensation or does it come back? How does that work?
Not necessarily. So nipple sensation changes are actually more common from just augmentation or any kind of implant placement. As the implant stretches on the tissue, it can stretch the nerve. So most changes are temporary. Patients may experience hypersensitivity where their nipples are so sensitive they can't even let the clothes touch them. They can have slight decrease in sensation temporarily. Usually by about 3 months, most sensation goes back to normal. Sometimes, unfortunately, they may have some permanent changes, but most of the time it is temporary. With the breast lift, usually there's not a whole lot of additional changes in the nipple sensation with the breast lift. It's more related to the augmentation and the stretch of the implant.
That's so interesting. That's opposite of what I would have thought. So from the inside, the implant is pressing against the nerve, and that could cause some sort of nerve reaction with the nipple. But from a lift and a reduction, you're saying it's a lesser risk.
A lesser risk because that nerve really comes with the blood supply. So unless there's a problem with blood supply, the nerve will also be intact.
It's so interesting. That's the opposite of what I would have assumed. Okay, what about a scarless breast implant? We hear that term used, but what does that mean?
So a scarless breast implant is usually refers to placement of an implant through an armpit. There's still going to be a scar, but it's going to be so well hidden, and the armpit is very forgiving. So that scar, once 3 months goes by, it's barely perceptible. So that's what usually refers to as a scarless breast lift or breast augmentation with an implant. There is other options for augmentation with minimal scarring. So fat grafting that I kind of touched upon. Fat grafting has become a very popular way to augment the size of the breast. There's a limit on how much we can increase the breast at a single session. So most often we do fat grafting more of a series. We may do 2 or 3 sessions to get the most desired effect. And depending on where we started with the particular patient. But in that kind of augmentation, the incisions are so tiny, they're literally needle points, so there is no true scars on the breast.
And then for someone who is having an augmentation with fat, how much of the fat stays behind over time? Is it everything that you inject from the beginning, or is it, does only a percentage of it stay?
It varies. So whenever we inject fat, there may be a little bit of fluid with it. There may be some of the cells that will not survive as a result of the transfer. There's going to be some swelling initially as well. So what they see the next day after the procedure is going to be a lot more fuller because of those factors. At 3 months is when they get their final look. And I would say at least 80% of that fat does survive. And so they get, on average, about half a cup size increase.
And who would be a good candidate for that procedure?
So anybody who already has a good breast shape. So one thing that fat grafting cannot change to the breast is more of that shape of the breast. So if somebody has very conical breast and they're looking to have a lot of roundness, the implant will be the best option. That's what's going to get them that round breast appearance. If they have pretty round breasts and they just need some volume, maybe at the top and generalized volume, they don't have any drooping of the breast, then they may be a candidate for fat. Second thing is they need to have enough fat for the transfer, so that we can get them the best result. If somebody's extremely slim, may not be a best option.
So you take the fat from a donor site on the patient's body.
Yes. So
typically, where are those sites?
The best option is the abdomen. And my second preferred method is from the inner thighs. So even
is there a reason you choose that fat?
So in studies, the fat from the abdomen has been the best donor site. It's the most robust fat that really survives well. It's usually very easy to harvest as well with minimal downtime, no scarring really. Second option is going to be the inner thigh, because even the slimmest of patients will usually have a little bit of fat on their inner thigh. So it's my second go-to in a slim patient. Other areas like the back, arms, they're going to be a more fibrous fat, so you're going to get a lot more fibrous tissue rather than true fat cells.
Okay, and then what about, you mentioned the back area, you know, the side where you get like a little side boob coming out of your bathing suit or your bra. When you're getting a reduction or a lift, is that part of the surgery? Can you also contour that area? And then how do you do that?
Absolutely. So I address that with every patient when they come in. So if I see a little bit of that fat puckering on top of their bra, that's the little bra bulge. I always want to address it for them because I want them to get the best result possible. So that would be with liposuction. If they have a little bit of that roll extending from the breast, which some of my fuller patients with larger breasts may have, we incorporate liposuction as part of the procedure to help contour it so their bras fit better.
So it's not part of the lift. It's like an adjunct to it.
It's a little adjunct, yes.
Yeah.
But I always want to address it because I want them to get the full nice picture.
Right.
Because patients, they don't focus on those things when they have the main concern. But once the main concern gets addressed, then they say, oh my gosh, I wish
then it's going to
thought
be
of this.
Right.
But I think of it for them.
Smart. Okay, so how much downtime should you expect with a breast surgery? I know they're all different ones that we talked about, but just, ballpark, how much should you bank just to stay home and not, go back into society? And when can you start going back to the gym, go back to work, all of that stuff?
So all of these procedures are done as outpatients. So patients have surgery, go home the same day. They're up and walking. They're not in bed. Most patients will drive in about 3 or 4 days. I do see them back pretty often to check on them, but 3 or 4 days is the most common timing for driving. Working, I always, depending on the type of work that they do, because the main limitation they will have is no heavy lifting, nothing super strenuous where they increase their heart rate, and nothing bouncy with the implants because we don't want to pound them down.
Yeah.
But if they're doing a desk job or light kind of work, they can go back to work within 3 or 4 days. If they're more active, if they're nurses or somebody who works with their hands a lot, I recommend at least a week. And then again, just limiting the heavy activity for about 6 weeks.
Going back, you said 3 or 4 days, right?
Mm-hmm.
If you have a sit-down office job.
Mm-hmm.
And then those first few days of recovery, should you be lying on your back? Should you be sitting up? What's the best way to sort of, recoup?
So as far as sleeping, it's always best to sleep on your back with a little elevation because of the swelling. And with the implants, patients will feel pressure. So having a little elevation helps at night. So that's going to be the best position for sleeping. The prescriptions I prescribe them are non-narcotics, so they actually are able to drive once the anesthesia medications gets worn off. They can think clearly, they can feel comfortable to make decisions. If they work from home, I mean, technically they can start working from home the next day.
Right.
Tell them, make sure your head is clear, that the anesthesia medications has left your system and you can make sound decisions.
And what about traveling?
Traveling, we have patients that come in from even outside of Texas to get their procedures done. So I like to have the patients stay at least a week locally so that I can check on them at least twice before they head home. So I would say at least a week. And when they're doing their travels, of course, not lifting their heavy luggage, especially if they are carrying on and have to put it overhead.
Yeah, you want someone there helping you for sure. Okay, what are some things everyone should be doing before and after surgery? Should you stop taking any medications? Is there something, girdles that you should buy? And how long should you wear that shapewear if you need to? Things like that.
For any surgery, patients need to stop any aspirin or any blood thinners they may be taking. If they're under supervision of a cardiologist, they have to check with their cardiologist first, and we'd like to get a clearance from them as well. Ibuprofen, Motrin, Excedrin, any medications that contain ibuprofen need to be stopped a week before. Other things that can increase bruising are fish oil, so I want them to stop that. High dose of vitamin E, and large quantities of green tea. 1 or 2 cups a day is fine, but if you're drinking nothing but green tea all day, every day, then you need to cut down, because that
and smoking, right? No smoking.
No smoking. So smoking will compromise blood supply to that skin. So I let the patients know, your healing is going to be slower if you're smoking. You're much more likely to have issues with wound breakdown, skin loss, nipple potentially even loss as a result of smoking. Your scars are going to be a lot worse if you're smoking. So all the good reasons to stop. And smoking, it's going to be at least a month before and a month after. But if they stopped, I recommend they stop for good.
And then my other question was, garters or shapewear. So should you wear that after for a long period of time, and how does it really help you?
So for breast surgery, I usually have patients get comfortable sports bras.
Yeah.
Will sit lower on their chest. We don't want anything that digs into the incision. So I want that band to sit lower on the chest. I want them to give a little bit compression, but not too much, because we want the implants to drop. To be supportive. If we've done some more extensive liposuction on the sides, I'm going to want a little bit more compression on those areas. So we may use wraps, we may use a different kind of garment, some liposuction foam to kind of contour the area the best way.
Okay, Lori Dorman asks, why no tea? Why no excessive amounts of tea?
So green tea, not regular tea. Green tea actually causes more bruising and bleeding. And, that's been written in multiple journals. And I didn't believe it myself until we encountered one of our patients who was completely black and blue post-surgery. I honestly thought that maybe she has some kind of coagulation issues. Turns out that she drinks nothing but green tea. Instead of water, she drinks green tea all day.
Wow. So no excessive amounts of green tea.
2 cups are okay, but no supplements. So if people take green tea tablets, I have them stop it a week or 2 before. And if you're drinking 4 cups, I have you cut down to 2 cups.
Okay, and what is the best way? We talked a lot about scars. What is the best way to treat scars, once you're healed or as you're healing?
So initially, I use something called Prenue tape on all the incisions. So it's a waterproof glue tape that helps to compress the scar. It helps it heal better, but it also gives it a little compression. So I do believe it helps with the eventual scar as well. Once the tape comes off, which is usually around 4 to 6 weeks, we start patients on silicone therapy. So silicone is going to be the number one option. We use silicone gel as well as silicone sheets. So I have them do gel maybe in the morning and then put the sheets at night. And I want them to wear that for a good 6 months after surgery because compression and the silicone will help the scars remodel.
So the sheets provide the compression.
Compression with the silicone, yes.
And compression is part of the equation. It's not just the scar gel.
Absolutely.
Okay, got it. And then what was the product that you said originally?
Silicone gel. So there's lots of different brands of silicone gel. What I use in surgery is called Prenue, and that's a kind of glue tape that we put on the patient right after the surgery.
So it's part of the post-surgery or post-op care. Got it. So on our end, we're doing the silicone gel and the sheets and the compression. Okay, and my last question is, for anyone who is considering breast surgery, what is the best way to find and vet your doctor and find the right fit for you?
So number one is, make sure your doctor is qualified. Make sure the doctor performs these kind of procedures and does them very often. Look at reviews online. Look at their before and after photos as well. That would be kind of the starting point. Have friends, recommendations. There's groups on Facebook. There's a lot of information online, but I would double check every source just because there can be a miscommunication online as well.
So make sure they're board certified by ABMS or the American Board of Plastic Surgery. And you can go to newbeauty.com too and check for a qualified doctor like Dr. Bachilo, and make sure that their aesthetic matches yours.
Absolutely.
Right. Yeah.
So, and then the second, consulting with a couple of doctors and seeing who's going to be the best fit, who do you feel most comfortable, who does see your aesthetic fit, because, you want to, the surgery is just the start of the relationship because you'll be seeing that physician for a while. And so I say, surgery is not the end. Surgery is the beginning of the relationship.
Right. It's step 1 or 2. Well, thank you so much, Dr. Bachilo. I really appreciate you coming on and sharing all of your knowledge with us. And everyone go follow Glamour Plastic Surgery. And thank you again. Have a wonderful day.
Pleasure. Thank you.
Bye, everyone.
Bye-bye.